Thank you everybody for coming. I have to say, this is the second year in a row that we've had to move this little gathering from January to later on in the year. So I think somehow we need to start learning a lesson here about January in New York. But we will, what we're going to do is, we're going to do what we usually do, because we've been doing this for a few years, and I know a lot of you have been here before. So what we're going to do is we're going to try to go through some of what I think are the major topics that were discussed. We're going to break them down into different categories. And what we're going to do this year that's a little bit different than we've done before is I'm going to ask a few questions of you during this talk. And Danielle thought maybe we would do like a show of hands. I don't want to do that because I want everybody to feel like they should be able to just think in their head of what they think the answer is, and then figure out whether they have been updated in their understanding or whether they had it right all along. So I'm going to pose some questions as we go. I want everybody to think about what their answers would be, and then I'm going to give you my answers a little bit further on in the talk, and then when we do our Q&A, we can always revisit some of these things if you have questions. So when we do the Q&A, one more point. Everybody just please remember, I'm not going to answer personal questions about you, your health care, your family's health care, because it's really not possible or appropriate from the podium. So if you want to ask questions, let's do them in a more general way, and then maybe everybody will be able to learn. Okay? So we're going to get started. One of the things that I like to see at the San Antonio breast meetings is information about breast cancer prevention, which is such an important topic. And I think as time goes on and our treatment methods get better and better, we can't forget to focus on the idea of breast cancer prevention. So what I think was one of the really important talks about this that happened at San Antonio this year was a talk from the podium by Jack Cusick from the UK about long-term follow-up from a breast cancer prevention trial that was called IBIS-1. The name Cusick may be familiar to some of you that are familiar with the Tyrer-Cusick model, which is a mathematical model that Dr. Cusick helped develop to try to understand the risk for breast cancer in individual women. So we're going to start now with our first question for the audience. This is a true or false question, okay? True or false? Does tamoxifen, when it's used to prevent breast cancer, save lives? So think about your answer, okay? Okay, let's continue. So this study that Dr. Cusick presented at San Antonio was done quite a while ago. And in the study, women who were at increased risk for breast cancer based on family history or based on things like atypical hyperplasias were randomized to receive either tamoxifen or a placebo drug for 5 years. And at this point in time, these patients have now been followed up for a very long time, and so we have very interesting and mature data to look at the results of the study, which was only 5 years of tamoxifen, okay? So the primary endpoints had to do with how many people developed breast cancer in each group, but they also looked at a variety of other health-related outcomes I think you'll find interesting. When women were enrolled in the trial, as we would hope from a well-designed randomized trial, the two groups were really very well matched in terms of age, in terms of things like body mass index, in terms of how many patients were menopausal and how many were not. But what I'm going to draw your attention to, and I've got this highlighted here, is that there was a substantial proportion of women who actually were taking hormone replacement therapy while they were on this tamoxifen prevention trial. Now that's something that we don't do any longer when we do these types of trials. We exclude women that are on HRT because it does seem that taking hormones by pills, not by creams or vaginal creams and so on, but taking hormone replacement seems to neutralize the benefit of tamoxifen. So this is something we don't do any longer. Now in terms of just our critical analysis of the trial, you can see that it's kind of a fairly equivalent number in both groups who are on the HRT, so I don't think that it made a big difference between the two groups, but this is something that you have to acknowledge as a part of this trial that might have had some kind of an impact on the magnitude of the results. But in any event, this graph, which is an updated graph, looks at women who took placebo and tamoxifen and how many of them developed breast cancer, not just in the first few years, but now all the way out. You can see all the way out to many, many years after the completion of the trial. So what you see is that the women who took the placebo drug had many more cases of developing breast cancer than the ones who took tamoxifen. So that's a good result. It's not a big surprise, right? It's not news. We knew that tamoxifen is effective at prevention. But I'm going to draw your attention to a couple of interesting things. So first of all, when you go past the 10-year mark, and again, I want to remind everybody, they only took tamoxifen for 5 years, yeah? But when you start going beyond the 10-year mark, look at how these curves diverge from each other even more the longer the follow-up. It's very interesting because it suggests that even just that limited treatment with tamoxifen over here has a continuing benefit way out here. So that's interesting. You know, that's a very interesting development. And they did a calculation called number needed to treat. This is the number of patients taking tamoxifen that you needed to have in order to prevent one breast cancer case. And at the end of the follow-up, long-term follow-up, that number's pretty low. It's 22 women needed to be treated in order to prevent one case of invasive breast cancer. So seems to be that the drug had a lot of benefit, it lingered over time, and maybe even got better over time. Okay, but now interesting thing, they looked at the patients and broke them down in terms of the kinds of breast cancers that did develop, both in the early years of follow-up and in the later years of follow-up. So the early years are in yellow or gold, whatever that color is, and the later years are in this light blue. So as one would expect, the tamoxifen prevented breast cancers, so we knew that was going to happen. Okay. We also see that it prevented DCIS and invasive cancer, so that's good. We see, as expected, it prevented hormone-sensitive breast cancers. Once again, this is consistent with prior knowledge. This is a hormonally active drug. The only kinds of breast cancers that it prevents are the ones that are hormone-sensitive. But what was very interesting development is the recognition that within the very late years of this follow-up, patients had an increased likelihood of when they got breast cancer, the cancers were more often hormone-insensitive cancers, estrogen receptor negative cancers. And this was something that was a little bit new in terms of the understanding of the benefit of tamoxifen and how that changed with the long-term follow-up. Now, going further, they also looked at the development of other cancers in women who were in the placebo group and the tamoxifen group. And you can see a couple things that, once again, little bit of stuff here that we knew already. So in the tamoxifen group, there was an increase in the rate of developing cancer of the uterus, endometrial cancer. We knew that that was the case. Interesting, there was an increase in the risk of non-melanoma skin cancers. Not really sure what that's all about. What I found very interesting is that the tamoxifen group had a decrease in the number of colorectal cancers that develop. Now, these numbers are actually pretty small, so I wouldn't draw too many conclusions from this, but this was unexpected, and when something happens that's unexpected, it's always very provocative, and hopefully will lead to some additional research to understand why it might be that tamoxifen lowered the risk of colorectal cancer in women who took it. Going further, now with this very long-term follow-up, they were able to look at what happened to people in terms of mortality and survival. And you know what they noticed? Wow, this is very sensitive. Okay. So what they noticed is that, as again expected, more deaths from endometrial cancer, there was more deaths from other cancers, but interestingly enough, when you look at this one line about breast cancer deaths, you can see that a few more women in the tamoxifen group died of breast cancer than in the placebo group. So, answer to our question, think about what your answer was before you heard this, and now think about what the answer actually is. Now, this was once again a relatively unexpected finding, but probably happened as a result of the fact that in the very late years of follow-up, the women who developed breast cancer had a higher rate of the hormone-insensitive cancers. And that's probably what drove that number to be what it is. So Dr. Cusick's conclusions, again, what one would expect, long-term follow-up definitely showed that tamoxifen was capable of reducing the rate of development of breast cancer in women who took it, and that it was primarily about the reduction in hormone-sensitive breast cancers. I didn't present the data to you, but the benefits were greater for women who didn't take hormone replacement during the trial. Again, makes sense to us, it's intuitive. But very important, there was no reduction in breast cancer-related mortality associated with the use of tamoxifen. So the answer to the question I posed a few minutes ago, does tamoxifen, when used for a prevention of breast cancer, does it save lives? The answer is, doesn't look like it. It lowers the rate of development of breast cancer, but overall was not shown to reduce breast cancer-related mortality. And it is very possible that this effect in slightly increased breast cancer mortality was because in the very late years of follow-up, women who developed breast cancer had a higher rate of developing hormone-insensitive cancers, which tend to have a worse prognosis than the hormone-sensitive cancers. So this adds something to our understanding about the benefit of tamoxifen, about the long tail of benefit for tamoxifen years and years after stopping the drug, but it also gives us a sense of how in the later years you have to watch out for those estrogen-insensitive cancers that can happen to people who took the drug. And just to show you a little bit more data that's interesting about this, it's very hard to read this, don't expect to read this. This was some data from NYU that we presented at the San Antonio meeting, looking at women who developed new breast cancers and looking at the numbers of them that had used in the past tamoxifen or other hormonal drugs as prevention methods. And we certainly see that when these women developed second breast cancers, they were overwhelmingly hormone sensitive, because most breast cancers, especially as you age, are. We certainly saw the fact that many of these women were many years after stopping the tamoxifen, and that having taken tamoxifen in the past can change also the kind of treatment that women require when they develop those subsequent breast cancers. So I think this is provocative data from the IBIS trial, and I think we're going to see a little bit more about tamoxifen and what the long-term risks and benefits might be in the future, especially because there's a lot of discussion about extended use of tamoxifen, as you know. So the next topic I want to talk a little bit about is something interesting and important to me as a surgeon, which is the process of localizing women who have non-palpable breast abnormalities. So really what we're talking about here is the very common scenario today of women who have regular screening, mammographies, or other tests that identify abnormalities in the breast that are too small to feel. They're inapparent, you don't feel them on physical exam, and the patient is not symptomatic. In order to biopsy these abnormalities, some kind of imaging guidance has to be used. So whatever imaging modality identified it, mammogram, sonogram, MRI, is also then used to target it to biopsy it. But when patients need to have surgery, we also need to do something to help us find this abnormality within the breast and facilitate doing a more focused and refined operation. So that's localization. So again, I don't expect you to read this too much, but I'm presenting this slide to show you that there's a lot of interesting work being done in updated methods for localizing non-palpable breast abnormalities. Some of you are probably veterans of breast cancer or breast-related procedures. You remember about the localization wire that has to go in, right, take it to the breast. It's a whole story. So this is a little project that was done, started by Dr. Charlie Cox. Charlie Cox is a surgeon from Florida who developed radioactive seed localizations for non-palpable breast abnormalities, and they've now come up with an even better way to localize things in the breast to help the surgeons find them in the operating room using a very tiny device that has a little antenna on it, and it's like a radio frequency thing. There's no radiation involved. You can think of it like a little GPS. It's called the Savvy Scout, and it can be placed in the breast at the time of a biopsy or even up to a week before surgery. And then in the operating room, there's a very special probe that can localize it. You could hear it beep, 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 and then that helps the surgeon know where to make the incision and know where the tissue needs to be cut. This is a potential tremendous advance. We don't have to walk around from the cancer center over to the hospital with the wires in the breast. This can be done within a week of surgery. We don't have to create a lot of difficulty for the patient on the day of surgery. And we here at NYU are getting ready to start a trial of this little device called the Savvy Scout. Hopefully within the next couple of months, we're going to start using it. And I really, really hope that we're going to demonstrate that it's effective and that it makes the whole experience easier for the patient while allowing surgeons to have very good, accurate localization information. So stay tuned. Maybe next year I'm going to tell you about our results. Okay, moving on to DCIS. So DCIS, or ductal carcinoma in situ, as many of you probably are well aware, is the earliest form of breast cancer that we can find. It's stage 0 breast cancer. It's the stage where all the malignant cells are confined to the insides of the ducts. This is not a life-threatening disease, and it's a disease that tends to involve the breast alone without spreading to lymph nodes or other organs. There's a lot of controversy about the proper treatment for DCIS because it's not something that's easy to categorize sometimes, and we really are trying to make an effort to figure out how women can best be treated in a way that tailors the treatment to their disease. So, second question of the day, true or false? Women with DCIS who have lumpectomies always require radiation treatment after surgery. Okay? Think about it. Think about what your answer would be, and now let me show you some data. So I'm going to show you some data that was presented by Dr. Rajkovic from Canada. And this was a Canadian consortium looking at the DCIS recurrence score and trying to validate this in women who are treated with lumpectomy for DCIS. Now, a lot of you may be aware that we have the ability to look at the genetics of breast cancers, not the patient's genetics, but the genetics of breast cancers. And for women with invasive cancer, there are a couple of these assays that look at the genetics of the tumor and give information about prognosis. A couple of years ago at San Antonio, my colleague Dr. Solin from Albert Einstein in Philadelphia presented this new genetic analysis for DCIS that was developed in order to create a scoring for DCIS to help people understand what a woman's risk for recurrence of DCIS within the breast might be based on a genetic analysis of the tumor. And what these investigators did is to try to validate whether that score really worked or not. So this DCIS, Oncotype DCIS score is a multi-gene assay, and it looks at 12 genes expressed within the cancer tissue. It also includes some clinical characteristics, and when the score is computed for a particular patient situation, it comes out as a continuous score. In other words, it could be any number up to 100. Now, there are 3 pre-specified groups. So if the score is below 39, that's considered low risk for recurrence. If it's between 39 and 54, it's an intermediate risk for recurrence. And a high risk for recurrence would be associated with a score of over 55. Now, the individual estimates that are given by the score are about the scenario. If this patient has a lumpectomy alone with no radiation treatment, what would be the potential risk for recurrence at 10 years in that particular patient situation? So this study was done to try to see if the DCIS recurrence score really was effective, if it gave accurate and important information, and also to see if this scoring was also associated with recurrence when you adjusted for other factors about the patient's presentation, extent of disease, etc. So they looked at a data set from Canada where they have socialized medicine, there's very good capture of data, and they looked at cases from Ontario between 1994 and 2003, so that's a long time. There were 1,658 women with pure DCIS treated in that time period, but then they had to get the tissue blocks from the pathology. So they were able to find 828 tissue blocks. Of those was 828. 571 of those patients had had lumpectomies alone with negative margins. And then they looked at the tissue blocks, computed the scores, and looked at the patient follow-up. They defined local recurrence as the development of either invasive cancer or DCIS greater than or equal to 6 months after initial diagnosis and in the same breast. And because of the time period, the follow-up was very robust at 9.6 years. As you would expect, 81% of the patients were over age 50. The tumor size was pretty variable. What's a little troublesome about this data set is that in a fair number of the patients, they didn't have complete clinical information and couldn't really tell how large the area of DCIS was. So that's a little troubling. And the majority of these patients had DCIS, which was hormone sensitive. Over the period of time, there were 100 patients out of this entire study group who developed another episode of cancer within the same breast. 57 of those 100 were invasive cancers, and 44 were once again diagnosed as DCIS. So overall, in these women who were treated with only lumpectomy, the overall risk for getting a recurrence of cancer within the same breast at 10 years was 19%. And that kind of conforms overall globally with our prediction on this, that when you've had DCIS, there is a significant risk for getting another episode within the same breast, especially over a long period of time. But now here's where it gets really interesting. So they broke up the patients, they did the DCIS recurrence score on the tissue, and then broke them up into the 3 categories of high, intermediate, and low risk for recurrence, and then looked at the outcomes. And what you can see here is that patients in the high risk and the intermediate risk of recurrence did about the same, and the chances of them developing a second cancer in the same breast in the time period was substantial. It was about 30%. But you can also see that there was a population of patients in the low-risk group, right here, who clearly had a different outcome and had a very low risk, or a relatively low risk, of getting a recurrence in the same breast at 10 years of 12.7%. So it looks like the high and intermediate group did about the same, but you can really distinguish this low-risk group as separate and having a different outcome. Going further, once again, if you look at, just break it down, was the recurrence invasive or non-invasive, you can see here that the curves do separate. High and intermediate about the same, low risk is separate. Here, the high and intermediate group, you couldn't put a credit card in between these 2 curves. I mean, they're basically the same, but once again, that low-risk group settles out as doing much better than the others. Now, they felt that based on this information, the DCIS recurrence score was really helpful because you can distinguish that low-risk subgroup that had a relatively low risk of getting another episode in the same breast over a long period of time. And this, definitely seemed to carry out across all the clinical subtypes, tumor size, etc., different types of DCIS. The DCIS recurrence score really seemed to be predictive of outcome. So, conclusions. Now think about your answer. Does everybody need radiation therapy? Think about it. So the conclusions of the study, the DCIS score was associated with the risk for recurrence in a population of patients who were treated with breast-conserving surgery alone, and that it seemed to provide relatively accurate estimates of the risk of developing another cancer. So that this is something that could help improve decision-making for patients and physicians. And I think really where this is helpful is distinguishing that group of patients at the low end of the spectrum who have a risk of developing another episode of cancer in the same breast of about 12% at 10 years. And I think I would suggest, and suggested by the data, that women in that group are a group for whom radiation therapy is really not mandatory. Okay? And part of the reason why that 12% is such a significant number is that it starts to look like their risk of developing cancer in their opposite breast in the same time frame. And we certainly don't treat the opposite breast with radiation. So this is just further validation and another effort at refining our treatment by using genetic analyses of tumors. And I think we're going to see more and more use of this DCIS recurrence score to help in our decision making in the future. Oh, I'm sorry?
I have a question. This study was on breast DCIS with no margins involved.
Negative margins,
Right.
correct.
So people who had margins involved, how would that, how did the radiation treatment help?
Well, this study didn't address that.
Okay.
Everybody, I mean, it seems to be very clear that if you don't have adequate margins, that it increases the risk for recurrence in the breast, and radiation therapy may neutralize that, but we are, I think pretty much when you look at this as a research, requiring negative margins gives you a much better category of patients to look at where the outcomes should be more similar. Okay, we'll take one more question. I'm going to save questions for the end.
Just real quick, is that same gene analysis used for other types of breast cancer?
Well, this is a subset of the genes that are used in the Oncotype DX score that's used for patients with invasive cancer that is hormone sensitive. So there are a number of genomic analysis scores that are used for women with invasive cancer. Oncotype DX, Mammaprint, PAM50. So there's a lot of that work. Okay, moving on to talking a little bit more about surgery, because that's what I like to talk about. We're going to talk a little bit about breast reconstruction. And I'm going to show you a couple of slides that we're looking at trying to understand the use of breast reconstruction in patients in a variety of different clinical situations. So third question, everybody's keeping score on how they're doing so far. Third question for the audience. Does neoadjuvant chemotherapy, that means chemotherapy given before surgery, is that associated with an increased rate of complications when patients then undergo mastectomies with reconstruction? Okay, think about your answer. Okay, so this is a talk that was given about reconstruction for the high-risk patient by Dr. Golshan from the Harvard system. And the slide sort of, I apologize for Dr. Golshan's lack of punctuation, but the first slide was supposed to be trying to understand which patient populations might be at increased risk for having complications with breast reconstruction. Now, as one would expect, the factors that led to increased complication include the things that are always associated with increased surgical complications: advanced age, obesity, diabetes, smoking, emphysema, high blood pressure, etc. And what they found is that these patients who had these other medical problems definitely had more risk from breast reconstruction. What they also found is that for every additional hour of operative time overall, the complication rate increased by a significant degree. So again, not very surprising, but longer operations per se are associated with an increased rate of surgical complications. Moving on, Dr. Golshan also discussed the effect of radiation treatment on breast reconstruction. So this is a kind of a hot topic. As many of you may be aware, there is a sense that implant reconstructions suffer when patients have radiation, that it leads to an increased rate of capsular contracture and hardening of the implants and so on. Dr. Golshan presented some of this information and identified the fact that if the patients had implants and had prior radiation treatment, there was an increased rate of complications and issues. And a lot of things went along with that. Post-op infections also increased the complication rate and so on. But I'm going to draw your attention to the last line. The patients who had received chemotherapy before their surgery, that by itself was not associated with an increased risk from the mastectomy with reconstruction procedure. So I think that this is good information that leads us to be able to offer the option of mastectomy with reconstruction to patients with a history of chemotherapy without a grave concern about their complication rate. There was also a lot of discussion about contralateral mastectomies. As a lot of us know, more women today have been opting to have the unaffected opposite breast removed when they're having mastectomy surgery for breast cancer. And this is a trend that's been observed in the States for actually a number of years. And you can see from this slide that this lighter line is the rate of patients choosing to have this contralateral prophylactic mastectomy over the years, and you can see it parallels the rate of breast reconstruction. So in some way, the availability of good high-quality breast reconstruction has probably been part of this increase in the rate of women who are choosing to have their other breast removed prophylactically. Now, a couple of points here that may be also part of this trend. One is that women may tend to overestimate their risk of developing cancer in their opposite breast when they have already had cancer in one breast. So it's up to us as clinicians to make sure that patients have good information. Clearly, the use of genetic testing makes people much more aware of their inherent risk to develop another breast cancer, and that probably is supporting this trend. Preoperative MRIs may identify unexpected occult cancer in the other breast, or trigger biopsies and follow-up that make people opt out and opt for the prophylactic mastectomy. But it's interesting that although this is not scientific at this point, there is some sense that women, especially those in the very high-risk groups like BRCA carriers, who have this prophylactic mastectomy are certainly lowering their chances of dying from breast cancer. So I'd like to see a little bit more data about it. I think there's a lot of consternation about women maybe going down this road for bad reasons. But clearly this is something that's here to stay, and I think we need to understand why people pick this. We need to understand that better to help us understand why it may or may not be a good trend. So I'm going to talk a little bit more about lumpectomy surgery now. And I've shown this slide a couple of times here as well, because it underscores how important it is when we do lumpectomies to concentrate on the edge of the tissue, on the margin, and have the pathologist pay a lot of attention to the margin to help us understand whether the lumpectomy has been adequate or not. And I've presented data here in the past about the use of a device called the margin probe that can be used in the course of lumpectomy surgery to help a surgeon know whether or not a sufficient amount of tissue has been removed, or if there's a reason to take more tissue on one particular edge or another. And I showed you data a couple of years ago about a big pivotal trial that we were involved in here at NYU that led to FDA approval of this device for exactly this use. This data comes from Germany, where they specifically looked at the use of this margin probe in women with DCIS, which is a kind of a challenging patient population to do lumpectomy surgery in. Women with DCIS rarely have lumps. It's usually microcalcifications, so it's hard for the surgeon in the operating room to tell where the disease actually ends. It tends to spread microscopically. And what the surgeons in Germany showed is that use of the device really helped them lower the number of patients who wound up having inadequate margins and needed a second operation. So this further supports the use of this device. We're using it at NYU. I think we've been pretty happy with our results. And for me, this is another way to support breast conserving surgery in women who are good candidates. And we always want to make sure that women have this option available. Now this is another slide you can't read. That's like specializing in slides you can't read this year. So this is another slide you can't read, but I'm going to show you stuff you can read. Bear with me for a moment. And this is I show you this very preliminary data about a new method of looking at the margins that was studied in the UK. And this is something called the InTouch System. So this is another intraoperative imaging device that actually tries to obtain almost a photomicrograph that the surgeons can see in the operating room and help them understand if additional tissue needs to be taken out. It's a different technology than the margin probe, but trying to accomplish the same thing. So what they did here is looked at a few roll-in cases, just a number of cases that they started out. They found that, as one would expect, the device was designed to be as sensitive as possible. So never want to overlook a cancer area. As a result, it's not very specific. So this is a trade-off. If it's very sensitive, then sometimes it's going to pick up things that it will identify as cancer that are not really cancer. That's a trade-off, but you can see why you would design it this way. And the investigators concluded that the device was easy to use, it was safe, no one had any adverse effects from it. What is going on here? And it has the potential to help reduce the risk of needing a reoperation in women having lumpectomy surgery. So I'm presenting it to you today so that you are aware that a lot of different modern technologies are trying to be adapted to medical uses. And this is all great because it'll eventually help us refine our surgery even further. There are optical imaging methods that are being investigated too, and I hope at some point in the future the lumpectomy surgery will be a little bit more guided than the way that it's done today. Okay, so what a lot of you are probably really interested in hearing about is systemic therapy for breast cancer. So we're going to talk now a little bit about medical treatments for breast cancer and some interesting data that was presented at the San Antonio meeting. So Mitch Dowsett, who's a very world-renowned researcher, gave a wonderful talk, a keynote lecture, about hormonal therapy for breast cancer and asking the provocative question, is endocrine therapy relevant today when we do all this in-depth genetic analysis of cancers and we're trying to develop all these targeted therapies to the genetics of the cancers? What role is hormonal therapy going to have in the future? And it was a really terrific talk because it went through a lot of the history of hormonal therapy. Now, by the way, I should point out to all of you that the San Antonio meetings have a website, and all of this information is something that you can actually get access to, and you can look at this stuff on the web. Some of it you can actually see audio and video, and if there's anything that you're interested in, you know, it's up there, it's available. So he started out by talking about the history of hormonal therapy and focused a little bit about the ATAC trial, which was a trial that was done a while ago. You can see it was published in The Lancet in 2002. And this was a trial at the beginning of aromatase inhibitor therapy, trying to help understand how aromatase inhibitor therapy compared with either tamoxifen by itself or the combination of tamoxifen with aromatase inhibitor therapy. And very briefly, what the trial showed is that the aromatase inhibitor anastrozole gave better results than either tamoxifen alone or the combination of the two drugs in sequence. Okay, so the aromatase inhibitor did better than either tamoxifen or the combination approach, and this is clear going out to 10 years that tamoxifen alone versus the aromatase inhibitor, the patients did better with the aromatase inhibitor. And this was really the first trial that strongly established that for postmenopausal women, aromatase inhibitor drugs were going to be preferred to tamoxifen for treatment. Now, since that time, there's been a lot of refinement about looking at this hormonal therapy, trying to understand which patients will respond, which patients won't respond, which patients will develop resistance, etc. And the IMPACT trial was a trial looking at hormonal treatment, but before surgery. So in the neoadjuvant setting, before surgery. And this is a nice trial design that you're going to hear a lot about today and in the future, because it allows us to use different medications for a short period of time and monitor response in certain ways before the patient goes to surgery. So in this trial, patients had biopsies done. They were demonstrated to be hormone-sensitive cancers. They were treated. They were then biopsied again, and then an additional time lapsed, and then biopsy was again done, and they were monitored throughout this time to see what the responses were like. While they were being biopsied, it was not just looking at whether or not there was cancer present, because that was a known quantity. The purpose of these repetitive biopsies was to look at something called Ki-67. And that's a marker that we look at in the tumor that is sort of a rough reflection of the growth rate of the tumor. Ki-67 is sometimes called proliferation index because of that. And what they found in the trial is that this Ki-67 changed a lot more in people who were just taking the anastrozole, the aromatase inhibitor, than patients who were either taking just tamoxifen or the combination. So once again, if you're looking at that Ki-67 as a measure of effectiveness, it looks like that aromatase inhibitor did better than tamoxifen or the combination of the two drugs. So this is not just looking at outcomes, it's really looking at the biology of the cancer. And this is a complicated slide, but what they did is they individually plotted people's change in this biomarker over time. And you could see, again, that lots and lots of patients had this marker go down while they were being treated, but interestingly, there were a few patients for whom that just did not work out. Instead of the proliferation index going down, in some patients it went up, or it stayed the same. And you can break people out into these groups by whether their Ki-67 went down or it didn't seem to respond appropriately, and it did look like you can distinguish between different groups of patients in terms of overall outcome just based on this characteristic. So kind of looking towards developing something that you could measure and monitor as an index of response to treatment when using this hormonal therapy. So the next study that of course came out of this was the idea that perhaps you could develop a panel of some of these different qualities that could be studied and tracked over time to see whether you could distinguish a group of patients who were going to do so well with hormonal therapy that they did not need chemo. Okay, so again, a recurrence score was attempted to be developed using these genes, the proliferation genes, invasion genes, etc. It included estrogen progesterone receptor. And once again, it seemed to show that patients in the three groups discriminated themselves pretty well, with the low-risk group standing aside a little bit. Now, one thing I think you need to look at here is beside the separation of these three curves, which, you know, from the high to the low, if you look at the top to the bottom, that's a big separation. But the thing you really need to see here is that the vast majority of these patients did extremely well over 10 years of follow-up. Okay? In the low-risk group, 94.4% of people had no recurrence in 10 years. That is just spectacular. So one message is that our patients are doing better and better over time, and it's a very positive message for people to receive. But what they also did was to try to determine if you could measure some of these biomarkers in the tissue from the original diagnosis and see if it correlated with the long-term outcome. And there does seem to be some discrimination. As you would expect, the patients who had the HER2 positive cancers overall versus the HER2 negative, there was a big difference. Being HER2 positive is an established measure of biological aggressiveness. But once again, if you look at the Ki-67, there's some separation. ER and PR a little bit less so. So this led to the development of a scoring system based on just those four qualities that seem to lead to some separation between the groups of patients. So estrogen receptor, progesterone receptor, HER2, Ki-67, which these researchers then combined with some clinical characteristics like the size of the tumor, whether or not it was in the lymph nodes, the grade of the tumor, the patient's age, and whether or not they took endocrine treatment. And you can see in these curves, separated out by nodal status, that there does seem to be some ability of this score to distinguish which patients would do well and which patients did not so well with endocrine therapy. And if you look at this top curve right here, again, you know, you can see that you can find a percentage of patients that are going to have a higher probability of recurrence, but if you look at the lowest curve, patients with negative lymph nodes, scores very, very low, these patients had an almost negligible risk of metastatic disease over time, which would suggest that chemotherapy was not necessary and that they could be treated with endocrine therapy alone in a safe way. So as we're thinking about where the direction of breast cancer treatment is going, one of the important things that's happening is drilling down harder and harder on understanding the primary tumors as much as we can, because that will help refine and stratify treatment. And this genomic analysis of tumors, we're just at the very beginning of this effort. We're going to see a lot more of this as time goes on. On the same note, this is another trial that's being done. the Poetic Trial, because you have to have a really good acronym before you even develop a trial, I believe. You have to do that. And this is about trying to figure out which patients have characteristics that suggest that they're going to become resistant to hormonal therapy. They're not going to respond. So what we're doing over here is a biopsy of the tumor at the baseline, a whole profile of the genetics of the tumor, and then aromatase inhibitor treatment for 2 weeks, and then the patients are going to go to surgery, and we're going to figure out what kind of changes they've had in their profiles and see if it correlates down the road with ultimate outcome. And I think we're onto something here, and I hope next year and the year after you'll hear more about this. Now, this was even really further looked at by Dr. Dixon, who we've seen some data from him earlier in this talk, looking at genomic analysis of hormone-sensitive cancers and focusing on the ones that did develop resistance to hormonal treatment. So they looked at patients who had hormone-sensitive breast cancers. They were given letrozole, which is another aromatase inhibitor. They didn't have surgery. They just took the medication. They looked at people who did not respond, who did respond, or who really didn't show any effect whatsoever. And then they biopsied these patients repetitively to look at how some of these genetic and genomic characteristics changed over time. And what they found is that for some patients, they definitely showed a change in the tumor, in the actual tumor tissue, and the tumor characteristics over time. And looking at the patients, they could develop a kind of a nomogram here, or a graph, that showed what proportion of patients responded with time based on their tumor characteristics. Luminal A cancers are hormone sensitive, HER2 negative, tend to be the lowest grade of cancers. Luminal Bs can be hormone receptor negative, HER2 enriched, as we said, is a little bit biologically aggressive. And you can see that in the luminal As, you can see lots and lots of response, but the non-responders, you have more of them in the luminal Bs and the HER2 new. And they developed this model looking at several genes that they felt were associated with whether or not people would respond, that if these genes changed over time, you could predict almost whether someone was going to respond or not respond to treatment. And then they identified the fact that as patients went on with endocrine therapy, the cancers that the people who really were responding, their cancers were shrinking, what they saw is that the cancer genetics got better. They had fewer and fewer mutations with time, but that the cancers that didn't respond, that grew or didn't respond, their cancers actually developed new genetic abnormalities over time. They felt like you really couldn't predict this based on the way things looked before treatment was begun, but that as you track people through treatment, you could see how the genetics of the tumor changed, and that was a lot more predictive, and that they felt that the model of these 4 genes that they suggested seemed to really predict response to this medication, letrozole, which is an aromatase inhibitor, with a high degree of accuracy. Now, this is a really provocative, interesting first level of analysis. We've got to do a lot more, looking at more patients and over a longer period of time to see if this genuinely is predictive. But if it is, I think it will once again help refine our understanding of who's responding to these treatments and who is not, and also maybe even shed a little light on duration of treatment. So stay tuned here too. The next study that I'm going to talk about pretty briefly, I'm mentioning because it's one of a number of different studies that were looking at the immunotherapy for breast cancer. So immunotherapy for breast cancer is relatively new. We all know the major categories of breast cancer treatment: chemotherapy, hormonal therapy, targeted drugs like Herceptin. The concept of using immune modulation for breast cancer is relatively new, but seems to be that this is going to be a really important avenue for research in the coming years. So this was a phase 1 study, so very, very preliminary, of something called pembrolizumab. I can't even say that. Particularly in patients with advanced triple-negative breast cancer, and we all know triple-negative breast cancers are difficult to treat because they don't respond to either hormonal therapy or Herceptin, and chemotherapy has up until now been the only way to treat these kinds of cancers. So this is going to introduce you to another set of facts about cancer cells and how they get to grow and establish tumors in the body. So there's something called PD-1, which is something that is expressed on activated T cells. T cells are immune cells that help fight off infection and other invasion. And this is something that is expressed on these cells. This is a receptor, and when the ligands, called PDL1 and PDL2, when they come along and they interact with the receptor, it impairs the T cell function. So the T cells want to do the right thing, but when these chemicals, when these agents interact with those receptors, they block the T cells from helping to fight against the foreign substance, which may be a tumor cells. And it turns out that this substance that interacts with the receptor is expressed on tumor cells and macrophages in the blood. So this is interesting because it kind of suggests that there's a way that tumor cells can dampen the immune response, and perhaps that's a way that they can establish a beachhead and then grow and develop. The pembrolizumab is an antibody that acts against this PD-1. So this was specifically developed and targeted to exactly this pathway. So the researchers presented this trial, Keynote 012, where they specifically were looking at, remember this is very, very preliminary phase 1, looking at people with recurrent or metastatic triple-negative breast cancer. They looked at their tumors to make sure that the tumors expressed that PDL1, that compound that can evade the immune system. And then they gave them the drug, the pembrolizumab, and looked at how patients did and what the responses were. And this is what they found. So remember, this is again a really small study. There were only 27 patients who were enrolled in the study. So this is very preliminary. Out of the 27, 18.5%, or a total of 5 people, showed some response to the drug. So this bar is set pretty low, yeah? But it's interesting, okay? If you go further, one of these patients had a complete response. The cancer seemed to go away. They didn't see any evidence of it. But more patients had either partial responses or stable disease. And unfortunately, some of the patients actually progressed while they were on the drug. So it's a bit of a mixed picture, okay? But as it turns out, and I didn't show you this data specifically, some of the responders, so 3 out of the 5 responders, responded extremely well. So these were people that were in a bad situation. They had recurrent or metastatic triple-negative breast cancer, really tough group to treat, and only 5 responded, but 3 out of them had responses for more than 11 months, so almost a year. That's really a very big deal. That's a really significant fact. Now, certainly this is very preliminary, and it's unfortunate that only a minority of patients responded. But it also seems like the ones who did respond, some of them had very long-lasting and durable responses. So there may be something special about those particular patients that distinguishes them as being particularly sensitive to this immune therapy, and could be a really active area for investigation and the development of specific immune treatments in the future. And there was a lot of other information about immune therapy for breast cancer. This is going to be a very hot new topic in the next few years. So lastly, I want to talk about the SOFT trial. Now this is something that was discussed at San Antonio. It was discussed in the New York Times, and it's now been published in the New England Journal. So this was something that created a lot of excitement because this trial was supposed to help us understand, answer a question that's been a very open question for a number of years. So I'm going to pose my last question to the audience. You're going to get to ask me questions later. This is my last question to you. So here's a question. In premenopausal women with breast cancer, who have hormone-sensitive breast cancer, is it better to, in addition to giving tamoxifen, to suppress all the ovarian function? Is that a better treatment than just using tamoxifen alone? And that's one of the questions that this trial was designed to answer. So think about what you think your answer is right now. Okay, so let me show you what the schema is for this trial. Soft suppression of ovarian function trial. Again, I don't know who comes up with this stuff, but it's really, really good. So these were over 3,000 patients who were randomized. These were premenopausal women with hormone-sensitive breast cancer. Some of the patients received chemotherapy as part of their treatment based on physician decision-making and recommendation. But not everyone received chemotherapy. They were randomized. There were 3 groups. One group just received tamoxifen for 5 years, which was the standard at the time. One group received tamoxifen plus ovarian suppression. And the ovarian suppression was done either with an injectable medication, with removal of the ovaries, or with radiation of the ovaries, which we really don't do anymore. And the third group were patients who had ovarian suppression and then instead of tamoxifen took exemestane, which is a third drug in the aromatase inhibitor category. We've now heard information about all 3 of these drugs. And the median follow-up at the time of reporting was 5.6 years. So what did they find? So first of all, if you look at these 3 groups in terms of just percent of patients alive and disease-free, again, the vast majority of people did really, really well. So this is a really positive take-home message here, and I can't emphasize it enough. But once again, if you look at these curves, they're really superimposed. You don't see a difference between the 2 groups in terms of overall being alive and disease-free. As one of my colleagues likes to put it, you couldn't put a credit card between those curves. I mean, these are superimposed. There's no difference. So the authors broke it down a little bit more and tried to look at more specific outcomes. This is just disease-free survival, and this is breast cancer-free survival. And although you're starting to see maybe a tiny little bit of distance between the curves, that's a little too close to call. And from a statistical perspective, the p-value is not significant. So once again, really not seeing a big benefit to adding ovarian suppression to tamoxifen or to exemestane. But now they looked a little bit further to people who had had chemotherapy and people who did not have chemotherapy. Now, remember that the patients who received chemotherapy overall probably had more disease and more advanced disease than ones who did not. Okay? This was based on physician choice, but I think that that's a reasonable assumption. So again, look at patients who did not have chemotherapy. These curves are just totally identical, superimposed. But if you look at people who had chemotherapy, you're starting to see maybe there's a little bit of a benefit here. Maybe the ovarian suppression, either with tamoxifen or with exemestane, might be a little better than just the tamoxifen alone in this very specific subset of women in this trial, okay? And if you go further, and now you're looking at stratifying the patients by age, if you just look at women who were below 35 years of age, okay, so really the youngest group of women in the trial, here is the one group where it seems to be pretty clear that there may be a separation of the curves with a benefit suggested for using ovarian suppression with tamoxifen or with exemestane versus just using tamoxifen alone. Now that's a very specific subgroup. It's the youngest women with cancer. These women also overwhelmingly received chemo, so certainly the overall figures in terms of their overall survival is definitely they have benefit from the chemotherapy as well. But what the soft trials seem to show us is that the majority of women have really no benefit from the addition of ovarian suppression, except there may be a little benefit in women who've had prior chemotherapy, and very particularly in women who were under 35 at the time of diagnosis. So again, in answer to our question, the answer is for the majority of women, the addition of the ovarian suppression did not really seem to benefit them in terms of their breast cancer outcomes. And certainly we understand that the ovarian suppression was associated with menopausal symptoms and other consequences. So it does give us a little bit of caution about using ovarian suppression in the majority of premenopausal women, but does suggest that we might at some point be able to identify an individual subset of women for whom the ovarian suppression, the benefit might outweigh the risk. So a little disappointing, not a big home run, but gives a little more information about the refinement, again, of the use of endocrine therapy in premenopausal women. So those were all the studies that I wanted to talk about. That concludes my prepared comments, but I would be very happy to take some questions from the audience.